all over the world, maybe good morning in some parts of the world. It's a great day to have Grappa again happening every September each year. This is the third or fourth time, I believe. Being a Grappa member, I mean, it's a pleasure to host Grappa here, which encompasses rheumatologists and dermatologists, always looking at the different aspects of the disease, the 6, maybe 7 domains now of the disease. We have a wonderful agenda for today and tomorrow. The agenda today will be from Dubai time from 7 to 9:30. And tomorrow we have a morning session and an afternoon session as well from 2 to 4:30. Today is virtual and tomorrow it's going to be hybrid, as some of the attendees here in Dubai will be attending the session in person. I'd like to thank Grappa, represented by all of the speakers today. Like my colleague, Professor Philip Hallowell, who will be introducing the meeting after me. And like to thank Novartis for their fantastic grant to support this meeting, and Infomed for organization. So Philip, the floor is yours. Thank you.
Thank you very much, Waleed. It's a pleasure to be back. I'm sorry that we can't actually be here in person in Dubai, but at least we're able to hold the meeting thanks to this wonderful thing called the internet. And we're all used to Zooming nowadays, even me, which is saying something. So it's a pleasure to be here representing Grappa. We have a stellar cast, as it were, today, some plenary lectures with international speakers and then local faculty. I'm hoping that the agenda will be shown right now. I can't see it on my screen, but I can share my screen with the agenda if you would like. Here it is. So we're going to have 4 talks this evening for you. First of all, as is only right and proper, the pathogenic concepts in psoriatic arthritis and psoriasis and the role of emphysis. Coates will talk about the treatment recommendation, the latest Grappa update. And then Dennis Pedubney from Berlin will talk about axial psoriatic arthritis, a very hot topic. And finally, Laura Savage, a dermatologist from Leeds, will talk about what the dermatologist should not miss. In other words, how we should be getting towards an earlier diagnosis of psoriatic arthritis. And then we'll have a short Q&A session where you can question the international speakers before moving on to local best practice, sharing effective collaboration with Dr. Ahmed Abu Gamal and Dr. Ahmed Amin. We'll discuss different aspects from a dermatologist and rheumatologist point of view. And very shortly, I'm going to give you a pre-meeting quiz, and later on this evening, I'll give you the answers. But I'd like you to vote. I'll just stop sharing my screen now. So I'm going to give you the quiz, and there'll be a QR code on the questions that you can scan and use that to vote in terms of the answers. So if we could show the quiz now, please. So there are 8 questions here, 2 from each of the 4 talks this afternoon. So the first question is, what is the most important cytokine in the development of psoriatic arthritis? Is it TNF alpha, interferon gamma, interleukin 17, interleukin 23, or transforming growth factor beta? If you can vote using the QR code on your phone, then please vote now. There is a QR code. I think I can see it in one of the screens up here. So I think, given the interest of time, we should move on to the next question, please. So there's a question. If we treat the skin, will it prevent the development of joint disease? You've got 4 options. Yes, for sure. No, for sure. Might do, or probably not. So there's some hedging answers there. So select your answer that you might think is true. Is it yes, no, might be, or probably not? Vote now, please. As I say, well, I'll give you the answers to these questions and discuss them with you later on. But of course, you will be given the answers during the presentations this evening. The next slide, please. So moving on to treatment. What drug treatments are recommended for axial PSA in the new Grappa recommendations? Is it number 1, TNF inhibitors only? 2, TNF inhibitors and IL-17 inhibitors? Is it 3, TNF inhibitors, IL-12/23 inhibitors and IL-17 inhibitors? Is it 4, TNF inhibitors, IL-17 inhibitors and JAK inhibitors? Or is it 5, methotrexate, TNF inhibitors and IL-17 inhibitors? So an interesting combination there, but only one of the combinations is correct. So please vote now, please. Thank you. Shall we move on to the next question? So this next question is about patients who have inflammatory bowel disease and uveitis, as well as their psoriatic arthritis. So they're 2 important comorbidities. So what treatment is recommended in the Grappa recommendations for this patients with PSA who have these comorbidities? Is it TNF inhibitors, number 1? Is it TNF inhibitors except etanercept? That's the second option. Is it TNF inhibitors and JAK inhibitors? That's the third. Is it TNF inhibitors and IL-17 inhibitors? That's the fourth. Or is it IL-12/23 and JAK inhibitors? Not all unreasonable suggestions, but there's only one correct answer by the Grappa recommendations. So please vote now. Thank you. So next question. So we're now talking about axial involvement in psoriatic arthritis. And the question is, what is required to diagnose the presence of axial involvement in a patient with psoriatic arthritis? Is it inflammatory back pain, a BASDAI score of more than or equal to 4? Is it active inflammatory or structural changes on imaging? Or is it an elevated CRP? Please vote now. And next question. Which class of drug is currently not recommended for the treatment of patients with psoriatic arthritis and predominant axial manifestations? Is it NSAIDs, a PDE4 inhibitor such as apremilast, TNF inhibitor, or IL-17 inhibitor? So this is which drug is not recommended, not which drug is recommended, which is not recommended. Vote now, please. And the next question, please. So moving on to the psoriasis questions, Dr. Laura Savage's talk. So the question is, patients with psoriasis at the following sites have a greater likelihood of developing psoriatic arthritis. So this is to do with the phenotype of psoriasis. Your options are A, scalp, palms, soles, and nails. B, natal cleft, knees, and scalp. C, knees, elbows, and nails. D, scalp, nails, and natal cleft. And E, palms and soles, natal cleft, and scalp. So an interesting combination of sites there. There's only one of them is evidence-based and is shown to give a greater likelihood of developing in PSA. So please vote now. And the final question, please. Which of the following statements is correct? And the first statement is, on average, patients with psoriasis destined to develop PSA do so 7 to 12 years after the onset of the skin lesions. Second option is, erosions are a late feature of PSA and are rarely present at diagnosis. Third option is, the Caspar criteria offer diagnostic criteria for psoriatic arthritis in patients with inflammatory arthritis. The fourth option is, the PEST questionnaire includes questions to help dermatologists screen psoriasis for patients for peripheral PSA. I think I may have missed peripheral and axial PSA, I'm sorry. I can't see all that. And the fifth option is, enthesitis of the proximal interphalangeal joint is nearly always found in early PSA, especially if the patient has nail psoriasis. So please vote of these 5 options, please. Not easy, these questions. Okay, so we'll come back to these at the end of the session. Thank you. So let's get this underway. It's my pleasure now to introduce Professor Kurt de Vlam, a good friend of mine, a dermatologist. Sorry, how could I say that? A rheumatologist from Belgium. You can see his bio there, but essentially, I'm not going to read all of this out, he's head of clinical rheumatology at the University Hospital of Leuven in Belgium. And he's principal investigator of rheumatology in the Skeletal Biology and Engineering Research Center of the Department of Development and Research in Belgium. Unfortunately, I'm not seeing all of that, so I may be missing bits out there, Kurt. But Kurt has a long history of research in this condition. I first met Kurt in the late 1980s when he was working with Herman Mielents and Eric Bays in Ghent. And we've had a very successful friendship and collaboration in this field since that time. So I'm very happy that Kurt is able to give this talk, and I'll pass it over to you, Kurt.
Thank you, Philip, for introducing me, and thank you to Professor Shegi and Novartis to hosting us again for the third or fourth time in Dubai. So it will be my pleasure to share with you some new insights in the pathogenesis of psoriasis and psoriatic arthritis, and especially the role of the antithesis in the development of the articular or the musculoskeletal symptoms. Okay, it's clear that skin involvement psoriasis is almost a mandatory condition for developing psoriatic arthritis. It's like over 85% of the patients have a history of present psoriasis, and only a few, like 10 to 50%, will develop psoriasis later, or even a small fraction might be never developed, but have a family history of psoriasis. It is clear that the process in patients with psoriasis begins with an interaction between genetic factors on the one hand for developing joint disease and environmental exposure. And this environmental exposure might be obesity, for example, or mechanical stress, or even infections. And we see over time that especially in these genetically susceptible patients, they might evolve to the development of overt psoriatic arthritis after some time, in general around 10 to 12 years. And what we see, in fact, that between the psoriasis phase and the psoriatic arthritis phase, there are a number of other, let's call it quiet phases, as preclinical psoriatic arthritis, subclinical, and the prodromal phase. And especially in what we see in this preclinical phase of psoriatic arthritis, that there's an aberrant immune activation phase with a focus and an important role of the IL-23 and IL-17 axis in the activation, and also in TNF production. And what happens is that this activation occurs upon some stimuli which can come from the gut or the skin. For example, we know that there are some microbiome alterations, or might come from some articular structures, for example, the antesis. And in a number of patients, these phases evolves in what we call a subclinical phase. And we know that this subclinical phase exists because with the development of new biomarkers and new imaging techniques, we were able to, in fact, document that there was like joint involvement or anthesial involvement in this phase. And then patients who are in this phase might be, probably hit by a second hit, which might be comorbidities or trauma or biomechanical stress, to evolve in the prodromal phase of PSA, which is characterized by arthralgias and fatigue, and later then in the classical PSA phase, the classifiable psoriatic arthritis, which is characterized by, as all we know all, enthesitis, synovitis, dactylitis, and even axial disease in some patients. So let's have a focus on what the antesis is, because antesis will become an important point here of the talk. The antesis is a structure which is abundant in the human body, and in fact is this place where the tendon inserts into the bone. And on the one hand, you have the tendon, on the other hand, you have the bone, and in between you have a zone of fibrocartilage with near the tendon you have the unmineralized fibrocartilage, and near the bone you have the mineralized fibrocartilage, and both zones are let's say demarcated by what we call the dyed mark. And the antesis plays an important role in the human body, because the antesis is an organ, is a structure which plays a role in mechanical stress dissipation, which is very, let's say, very useful in the human body. And as we all see, there are many anteses in the human body, and here you see those anteses which are frequently involved in spondyloarthritis and psoriatic arthritis. But of course, the question is, how can we link, in fact, inflammation at these anthesial sites to to the development of synovitis? Well, it is that the anthesis, or the definition of anthesis, is not only restricted to the tendon insertion in the bone, but also, let's say, the insertion of the joint capsule is also considered as an anthesis, which is depicted here in the middle. You see that where the articular capsule inserts in the bone, we see also an anthesis, and this is near the muscle and the menisci. And we know this now from new imaging techniques that, in fact, the insertion of the capsule in the bone plays also a role in, let's say, the development, or is also present in patients with psoriatic arthritis. So it was a long time, it was thought that, in fact, the inflammation at the anthesis produces pro-inflammatory cytokines, and that these cytokines are, let's say, pushed into the cavity, the joint cavity, and will develop a kind of secondary synovitis. But since then, in fact, the insides has evolved, and it seems that it's somewhat more complicated, complex than previously thought. And to understand very well what's happening now, we should introduce, in fact, a new concept, the concept of the Antegel organ. And the Antegel organ is not only the focal insertion of the tendon or the capsule into the bone, but is in fact the insertion with all the adjacent structures around the joint, including the synovium and the menisci. And this is very important to understand this concept, to understand why some locations are involved in the joint or in psoriatic arthritis or not. And here you see an example of this, let's say, Antegel organ. This is taken from the Achilles tendon. On the one, the yellow part is the bone. That's the black dots part is the yellow part is the tendon or the Achilles tendon. The black part is the bone. And you see that both sides are covered by this blue region, which is fibrocartilage. And the cartilage itself is, the fibrocartilage is covered by the synovial membrane, which hosts a lot of macrophages in their natural state. And this is a very important feature because what we see is that, in fact, these macrophages, they are near the places of, let's say, mechanical stress, and they can, in fact, their anatomic proximity can explain why, upon stress dissipation, upon degenerative changes due to mechanical loading, they can provoke a kind of inflammatory response. And this inflammatory response is, in fact, what we call the enthesitis. And this can explain also why inflammation can occur into the joint and not only on the enthesial insertions. So enthesitis is quite abundant as a prevalent feature in psoriatic arthritis. Over 50% of the patients will present enthesitis. And you see here in this graph that most of the patients have enthesitis on one or two locations. And the most frequent locations are, in fact, the Achilles tendon and the fascia plantaris insertion, and also the lateral and medial epicondyli of the elbow. And the question is, of course, can we pick up, in fact, patients at an early stage, let's say in a preclinical stage with enthesitis? Well, there is a very nice study from the Leeds group where they looked, in fact, with ultrasound at several entheses in patients with psoriasis, and they used the kind of the Glasgow score. The Glasgow score has both degenerative features and looks at inflammatory features. And they found by a lot of patients, in fact, a positive guess score, which indicates that there was inflammation at the site. And you see that is significantly more than what we see in controls. And interestingly, what they did is they follow up these patients, and what they saw is that, in fact, within 3 years, 40% of these patients developed clinically PSA. So yes, enthesitis or enthesial inflammation might be present in a subclinical phase, and might be, let's say, the sign or the point where the disease can evolve to an overt disease. And there's also asymptomatic arthritis. And in this study, you see that in patients, in the right table, you see patients with psoriasis vulgaris, and they were scanned with a SPECT-CT scan, and you see that in patients with no articular involvement, there was a signal on these imaging techniques, and they treated the patients also, and you see that even this signal disappeared after the treatment. So yes, from 2 points, there seems to be a in an early phase, in a subclinical phase, there might be inflammation available. So the big question is, what kind of pro-inflammatory cytokines or proteins are responsible or are involved in the development of enthesitis and in the maintenance of enthesitis? And it's obvious that obtaining human material to study what kind of cells and cytokines are present is not that easy. And most information we have or we obtained must rely on what I should call indirect evidence, for example, by using data from clinical trials or by studying typically animal models who represent features of psoriatic arthritis. And one of the indirect evidence is shown here, where we see that, in fact, patients treated with anti-TNF and also with anti-IL-17, and recently also with anti-IL-23, you see that those patients with enthesitis upon treatment improve over time. So indicating that at least these targets of these molecules, in the case TNF-alpha, IL-17, IL-23, must be present at the site of the enthesitis. Otherwise, we couldn't explain why this enthesitis is improving over time. So, and if you look at the more, let's say, overview, see, in fact, that this is quite constant for all kinds of drugs actually available, that most drugs showed significant improvement of enthesitis and also, for example, of dactylitis. So a second way to gain information about the mechanism is using animal models. And you see that enthesitis is in fact a common theme, a common feature in different rodent models, especially in the TNF-alpha driven models. You see that you find enthesitis around the joints, which is here shown by hip enthesitis. You see also that there is enthesitis at the classical entheses, for example, at the Achilles tendon, and you see that there is also enthesitis at the sacroiliac joints, also a feature of the psoriatic disease. And also in this model, and especially in the what we call the TNF delta ARE mice, which is a prototype model for studying the role of TNF alpha in psoriatic arthritis and spondyloarthritis, you see that in fact these mesenchymal cells are already activated before clinical onset, and it is nicely shown in this B table, where you see that these mice, after 12 hours, you see an upregulation of a number of typical inflammatory biomarkers like MMP3. So also in these animal models, we see that at the preclinical stage, this kind of cells, what we found back in humans, are activated. Another rodent model, which is mainly focusing on IL-23 and IL-17, and which has been published quite recently in the last 5 to 7 years. In these models also enthesitis is let's say a feature. If you look at the upper row, you see that there is a huge inflammatory infiltration upon injection of IL-23, and even that after almost 3 weeks, 18 days, you see also another feature is the fact of periostal bone formation and periostitis, which is also a striking feature of what we see in patients with psoriatic arthritis. And to go a bit more in detail, there was a mouse model where there was a systemic overexpression of IL-23, and it triggers a disease that mimics a number of aspects as we see in psoriatic arthritis. In the upper panel, you see, in fact, the control where they were injected with a alpha-1 antitrypsin minocircle, which is a kind of control injection. And in the lower row, you see the injection with IL-23 microcircle, and you see, in fact, a huge inflammatory infiltrate around the entheses after day 6 already, and after day 18, you see that, in fact, the bones start to react, and there is like periostal hypertrophy, and there is expansion of osteoblasts. And you see that this is in another model which was used, which is a more passive model where you control better the inflammation. Again, you see that in this model, before injection, nothing happens and there is no arthritis. But once you inject this IL-23 microcircle, you see that the clinical scores of these mice increase significantly, quite rapidly already after 4 days, and is at the maximum after 6 to 8 days. And in the second phase, what they did, they went and looked what kind of cells might react in this enthesis. And they found back that, in fact, a specialized type of resident T cells with an IL-23 receptor were present in the enthesis even before you provoke the inflammation. And there was not only enthesial inflammation, but as mentioned, there was also periostal bone formation. And you see on these slides here that the presence of alkaline phosphatase points towards activation of the osteoblast, and also the presence of TRAP, which is a staining for osteoclasts, is positive, showing that in fact both osteoclasts and osteoblasts are present, and points towards a kind of bone remodeling. And in the meanwhile, they found out that in fact there was not a direct effect of IL-23, but this effect will be mediated by the presence of IL-22, which promotes osteoproliferation. So this brings us to the hypothesis that probably a enthesis contains a number of unconventional T cells, which we call ILCs, innate lymphoid cells, which have a receptor for IL-23, and that in fact the enthesial micro damage can trigger a kind of tissue-specific inflammation and tissue damage, which leads to the production of this IL-23. And since these ILCs, in this case ILC3s, are positive for this IL-23 receptor, you can see that in fact at a certain point this induces a loop, and the local production and even distal production of IL-23, if the cells are triggered, can perpetuate to a cycle, a kind of vicious cycle. So in this process, it seems that IL-17 plays an important role. IL-17 is produced by gamma delta cells and these ILC3 cells, and together with TNF-alpha attracts neutrophils, which let's say is at the origin of an innate inflammatory response. This IL-17 also has, together with IL-22, has an influence on these mesenchymal stem cells, and these mesenchymal stem cells, they start to proliferate, and this might explain why there is new bone formation, because these mesenchymal stem cells, they produce all kinds of bone promoting factors like Wnt molecules and BMP molecules and head shock, which leads to bone formation, especially enchondral bone formation. And all this happens at this enthesis. So the question is here is fact, what starts, or what is at the basis of this IL-17 production? And it might be there are some hypotheses that, for example, mechanical stress might play a role, or disturbed barrier functions. And we know all the association also, for example, with gut inflammation in this patient group, but also with skin inflammation by the presence of psoriasis. And also there might be in some patients a role for infection. And all these triggers what have two characteristics. They start producing prostaglandin E2, which leads to vasodilatation, but also they are at the basis, or let's say they are at the origin of the production of IL-23, which in his turn stimulate gamma delta T cells and ILC3s. And upon stimulation of this IL-23, this cell starts to produce IL-17, and they start this whole cascade. So the question is what, as in the previous one, I showed that there might be some triggers. So there's some interesting data about mechanical stress as a potential trigger. And this work has been done in collaboration with our colleagues from Ghent University, where they looked at this delta ARE mice, which is overproducing TNF-alpha. And in a normal stage, if you put these mice in a cage and you make them running, they starting to developing enthesitis and synovitis. And you see that, in fact, after a couple of weeks, they have a quite high enthesitis score. So what happens is that all these mice were also tail suspended. And then what you see, in fact, that this enthesitis score drops, which might indicate that, in fact, joint loading or mechanical loading might play a role, at least in the maintenance or the increasing inflammation at these typical places at this enthesitis. And in a further experiment in another model, what they did is that they looked if there's a site-specific, if loading has a site-specific influence, and if there are site-specific localizations of inflammation and tissue damage. And they use a classical, let's say, collagen-induced model. And what you see if, in fact, you looked at the incidence of the disease at the hind post, then you see in the controls with the round dots that they develop disease, that the incidence is increasing over, let's say, days after almost 4 weeks. But in those mice who were unloaded, you see that hardly any enthesitis, any inflammation occurs at the hind post. And if you look at the forepost, and that is very interesting, you see that in the controls, they develop also enthesitis. But if you unload them while they're still working on the front post, you see that, in fact, the clinical scores of the front post is much lower than in the controls, indicating that not only the localization, but also the frequency, because it's, you can imagine that the tail suspended mice walk less or move less than when they are unsuspended. So also the amount of movement, the amount of loading has an influence. And you see that in a third experiment, what they did, they made this mice, in fact, extra running by a running wheel. And what they saw is that if you make them running in a running wheel, they even develop earlier inflammation and even to a higher extent. So it's clear that mechanical strain here of this data shows that mechanical strain is a potential trigger for inflammation in susceptible animal models, and probably also in susceptible, genetically susceptible patients. So to summarize, you see that IL-17 is an amplifier of enthesitis, which may lead to irreversible structural damage. And yes, mechanical stress plays a role, probably disturb barrier functions. And if I remember the program, I think my colleague Dirk Elowoud will talk about the role of microbiome in this immune activation tomorrow. So interestingly, how can skin also play a role? Well, there is interesting data from an imiquimod model, which is a model to study psoriasis in a mice model. And imiquimod, what happens is that, in fact, there is a kind of skin damage by a toxic product, imiquimod, and this elicits an inflammation, and which has a lot of characteristics of what we see in psoriatic plaque formation. And if you study these lesions, what you see that there is a huge production of IL-23 in this skin mice, and this IL-23 is produced by dermal gamma T cells and alpha beta T cells, but these cells also produce IL-17F and IL-22. And it's really an interesting paper if you're interested also in the connection between the nervous system and the immune response. What they did in the second phase is that they, in fact, they blocked the pain. They blocked the pain signal by nerve blocking. And what happens is that they saw, in fact, that the production of these pro-inflammatory cytokines dropped and was decreased. So, in fact, this is the first paper explaining a lot of elements from what we know as the Kapner phenomenon. So this brings me to a quite final hypothesis, and I think we know that now there are resident T cells at the antithesis. Interaction with an external factor in predisposed genetically predisposed patients might lead to the production of IL-23 on the one hand. Otherwise, interaction of biomechanical stress with genetically predisposed patients also lead to the production of IL-23. These stimulate these particular T cells, which are ILCs of innate lymphoid cells. And these cells are able to produce, on the one hand, IL-23, which plays a role in osteoproliferation and inflammation. And also they start to produce IL-17 and TNF-alpha, which plays again a role in inflammation, but also in bone loss. And understanding the role of these molecules can help us to understand a number of clinical and radiographic features we see in these patients. So understanding the role of all these cytokines might also help us to understand why actual drugs are, let's say, effective for some features and at some stages. You see here, to summarize, that in fact IL-17 and TNF-alpha are in a quite later stage in what we call the adaptive immune response. And we're all familiar with the efficacy of this anti-IL-17 molecules and this anti-TNF molecules. And recently, we also understand better the role of IL-12 and IL-23, and they are involved, at least in the earliest stage, in the innate immune response. And a number of molecules have been shown to efficacy also in improving signs and symptoms. But also the fact that they are involved at an earlier stage might also help explain why they don't work, at least for some late stage features. So that's, for the moment, the insights we have in the role of pro-inflammatory cytokines, together with the role of the antithesis, and how the antithesis might be at the basis of the musculoskeletal inflammation in patients with psoriatic arthritis. Thank you.
Thank you very much, Professor, for a very nice presentation. We leave the question, the Q&A to the end, hopefully. It gives me pleasure to introduce our next speaker, Professor Laura Coates. She's an associate professor at the NIHR as a clinician scientist whose research focuses on optimal therapeutic strategies in psoriatic arthritis. Her research is clinical and focuses on psoriatic arthritis and spondyloarthritis, including early diagnosis of psoriatic arthritis and development of PSA-specific and validated outcome measures, optimal treatment pathways and strategies in PSA. She's a member of the Grappa steering committee and the chair of the British PSA consortium, the Brit Pact. So without further ado, Professor Coates, the floor is yours. Thank you very much.
Lovely. Thank you very much. Thank you very much for everybody joining us. So I'm speaking today to give you an introduction on the Grappa treatment recommendations. And this is the third edition or the third update of the Grappa recommendations, which were previously published in 2009 and 2016. And obviously, while I'm presenting this work, there's a huge team behind me. I've listed them here. It involves a lot of different domain groups, a large number of patient research partners who've inputted as well. And this is very, very much a team effort. So these are my disclosures. And I'll put you to the disclosure at the bottom that these recommendations are currently in draft. We're aiming to submit the full recommendations in a week's time. And so there may be some minor changes which occur before then. So the goal of the Grappa treatment recommendations update was to continue work that Grappa set out right from the beginning of the inception of Grappa, where one of our key aims was to develop guidelines based on the best scientific evidence to optimize treatment for people with psoriatic arthritis. So this is very much the same as 2009, and we were aiming to bring together current approaches to guideline formation, good ethical standards, the best available evidence, and stakeholders, including patient research partners, to develop patient-centric treatment recommendations. So these are the recommendations which hopefully you recognise from 2016, and this was very much a domain-based approach, and this is the format that Grappa have followed from the beginning, where we've talked about 6 key domains of psoriatic arthritis and looked at treatment by domain, because often that's what influences our treatment choice. We very much wanted to stick with that domain-based approach moving forward this year. And so the domains in 2021 are exactly the same as 2015. So the 6 key domains of psoriatic arthritis, the peripheral arthritis, psoriasis, enthesitis, dactylitis, and axial disease. The only big change in this iteration is that we split out the comorbidities group into 2 separate groups. One called associated or related conditions. So this was recognizing the fact that inflammatory bowel disease and uveitis are not really comorbidities of psoriatic arthritis. They're part of that spondyloarthritis spectrum of diseases. And then the remaining comorbidities like depression, cardiovascular disease, liver disease, which remained in the comorbidities group. So there are 3 of us who've led this update of the Grappa treatment recommendations: myself, Enrique Soriano, and Arthur Kavanagh. We've had 2 methodologists from this systematic literature review. They're from the University of Kiel in the UK, and they're experts in systematic literature reviews, but not specifically in psoriatic arthritis. We then invited Grappa members to join the different domain groups and input into the recommendations. There were 2 domain leaders for each group, plus at least 1 patient research partner, and in most cases 2. The members were allowed to join different domains of their choice. That was an open invitation, and most people were in their first choice group. A few moved into their second choice group, with the aim of balancing people across the different domains and having between 15 and 20 participants per group. As you will know, if you're a Grappa member, these draft recommendations were sent round in a Grappa survey in May and June of this year, where we had 170 respondents, 9 of whom were patient research partners and 161 were clinicians. So the overarching principles remain broadly similar to back in 2015, although the new recommendation is this first one at the top, number 1, which really just gives an introduction to the recommendations and how these should be used. Recommendations 2 and 3 are the same as the previous recommendations. And as you can see here, there were just minor changes here to the recommendation around comorbidities, just to clarify the language and give further examples of different comorbidities. Also in the penultimate one, you can see here we changed the wording doctor to clinician to recognise the increasing role of other healthcare professionals, such as specialist nurses and physicians' assistants. What's clear through all of these overarching principles, if you look to the right-hand side, is there's a high level of patient and physician agreement with these from that Grappa member survey in May, June of this year. In addition to those overarching principles, we added 2 specific position statements, and these are new for this year because they represent issues that have really come to the fore since 2015. We didn't want each of the groups to have to deal and grapple with these problems individually, and this is where the position statements came from. So there's one position statement on biosimilars, because this is obviously a key issue that's hit our practice in the last few years. So this was to provide support around the switching to biosimilars, the importance of having patient engagement and patient involvement in those switches, and ideally that savings realised should then be utilised to improve access. You can see at the bottom there's a high level of patient and clinician agreement with these. The other position statement was on tapering and discontinuing therapy. And again, that's something that I think has come to the fore over the last 5 years or so, with increasing numbers, particularly of observational studies around tapering and discontinuation of therapy, but really not solid enough evidence to be sure who we can and can't taper treatment in. You can see here, this again talks about shared decision making, having patients involved in the decision, tapering slowly, and being aware of the potential risks of tapering therapy in terms of catching control of disease again. These had very high levels of support from the clinicians, but slightly lower levels of support from the patients. And that was particularly around the idea that remission may be considered in patients with low disease activity rather than only patients with remission. There was some concern that tapering may be done too early or in patients whose disease was not fully controlled. And that was the main issue that the patients raised with these statements. The methodology for the treatment recommendations used a grade-based format. We developed PICO questions, and these were refined within all of the domain groups. And then a systematic literature review update was run, focusing on randomized controlled trials. There was data extraction from all of the identified papers, and the quality of evidence was then graded, looking at the study design, any bias, limitations, or inconsistency of results. And that then allows you to assess the quality of evidence as high, moderate, low, or very low, and then think about whether the recommendations should be for or against a particular treatment. And for each recommendation, this can be a strong recommendation that you should offer this drug, or a conditional recommendation that you may consider this drug. And in some cases, you'll also note that there was the option for treatments to be put in a not enough evidence or conflicting evidence category if the evidence was just not clear enough to guide a recommendation either for or against the drug. So this slide summarizes the searches that were run. These were initially run in November 2019. You can see here on the left, identifying nearly 3,000 citations, about 400 full text papers, and in total, just over 100 articles which reported from 50 different discrete RCTs. Obviously, in early 2020, COVID hit, and we knew that there was going to be a delay in this process, given that people were required to go back to much more frontline duties. So given that delay, we updated the searches for the recommendations in August of last year, again picking out any additional citations that had been reported. You can see that's an additional 19 articles, and also doing searches of conference abstracts to pick up very new data, which was not yet published in terms of papers. There were additional searches run for the related conditions and comorbidities group, and that's because often these items are just not covered within the standard RCTs. So this summarizes the different searches that were done for that group. So thinking about treatment choice and comorbidities, screening for related conditions and comorbidities, reviewing RCTs in IBD and uveitis for additional information, and thinking about prognosis and phenotype linked to related conditions. So the first output of these recommendations is this table of recommendations. And you can see here down the left, we have the different domains of disease and different populations. And then running across the top, you can see we have strong recommendations for, conditional recommendations for, conditional recommendation against, a strong recommendation against, or no recommendation because of insufficient or conflicting evidence. In terms of changes from 2015, I think the most obvious change across the domains, and I'm sure you'll be aware as clinicians as well, is the availability of more mode of action drugs than we had back in 2015. So in 2015, we had TNF inhibitors, We had IL-12/23 inhibitor in the form of ustekinumab, and we had very early data on the IL-17 inhibitors, but that was in abstract-only form at the time. Since then, we've got additional data on JAK inhibitors, on the individual IL-23 inhibitors, the P19 inhibitors, as well as some additional data on some older drugs. So, for example, methotrexate. So you can see here now there are strong recommendations for many of the conventional DMARDs for all of those different targeted therapies that I've mentioned, the biologics, JAK inhibitors, and apremilast as well. Thinking about axial disease, we've got strong recommendations for TNF inhibitors and IL-17 inhibitors, also for JAK inhibitors, whilst recognizing that not all of that data is fully published. But we have a strong recommendation against conventional DMARDs because of their inefficacy. That's similar to last time. But you can see now on the far right-hand side, we now have IL-12/23 and IL-23 inhibitors in the insufficient evidence column. And that's because we have negative trials in ankylosing spondylitis patients, and we have only observational data from peripheral PSA trials, which suggests a potential increase in BASDAI. Thinking about enthesitis and dactylitis, I think the data follows a very similar pattern in terms of the inclusion now of newer therapies like IL-23 inhibitors. For psoriasis, obviously we have similar drugs, and again, many of our drugs have come from psoriasis first. And then in nail psoriasis, somewhat similar to 2015, we still have a lot of questions. You can see here on the right-hand side, a lot of drugs that don't have any strong evidence either way, but we have very good evidence and strong recommendations around a number of biologics and targeted synthetic drugs, and a number of conditional recommendations for other therapies. Because the related conditions were removed from the comorbidities group, they now appear in this main recommendations table. And it's important to note that this is not a recommendation for how to treat Crohn's disease or how to treat ulcerative colitis, because that would be well beyond our scope. What we're considering are drugs that you may well use in patients with psoriatic arthritis, and whether they would be recommended or not in a patient who has coexistent inflammatory bowel disease or uveitis. So you can see there's a strong recommendation here for the monoclonal antibody TNF inhibitors and for ustekinumab, both of which have licenses in inflammatory bowel disease. We have conditional recommendations for IL-23, JAK inhibitors, and methotrexate, given the data that's published in that group, and a strong recommendation against therapy with IL-17 inhibitors in those with active inflammatory bowel disease. In uveitis, we have a conditional recommendation for the monoclonal antibody TNFs, in particular adalimumab, but this didn't make the level of a strong recommendation because it's never been tested in spondyloarthritis-related uveitis. So adalimumab obviously does have a license for treatment of uveitis, but this is based on studies outside the SPA population. So what's really changed and why? So I just thought I'd cover a couple of the key papers that have really influenced the treatment recommendations this year. So this first one is the SEAM PSA trial, which I'm sure you'll be aware of. It was nearly 900 patients with quite recent onset psoriatic arthritis who were randomized to methotrexate in blue, etanercept in the red, or both in the stripy bars. And whilst this data clearly shows a benefit for etanercept over methotrexate, and that supports strong recommendations for TNF inhibitors in this group, it also provided quite good indirect evidence for the efficacy of methotrexate, and in particular, looking at methotrexate outcomes not just for arthritis, as you can see further on the left, but for enthesitis and dactylitis on the right-hand side of this slide. We have a number of current biologic therapies for psoriatic arthritis, and I've talked a little bit about how these have expanded since 2015. But this is a summary of some of the key phase 3 data for all of those major therapies. I think the big changes that have come since 2015 are the inclusion of IL-23 inhibitors. I'm showing here the data for guselkumab in terms of ACR50, PASI 75, and MDA. And then also the inclusion of data around JAK inhibitors in the form of upadacitinib. And again, I've got here the data from ACR50, PASI 75, and MDA in treatment naive or biologic naive patients from those phase 3 trials. In axial disease, we talked a little bit about the different therapies that were available. So we have new data on JAK inhibitors. They're very likely to provide the first effective oral treatment for spinal disease, which is very exciting. And we've also had the publication of a specific trial in axial PSA. So we have always complained in treatment recommendations in PSA that the recommendations usually have to extrapolate from AS or AXPAR studies. But in this case, the Maximize trial specifically looked at axial disease in psoriatic arthritis. On the slide, I've shown the data for the clinical outcomes for the ASAS responses, but as I'm sure you know from presentations that you'll have seen, there was also a significant improvement in MRI measures of disease, providing objective evidence that these drugs are effective for the spine. In contrast, we've had 3 negative studies now in ankylosing spondylitis. The first with ustekinumab, which was conditionally recommended back in 2015 because of an open label study, but was subsequently tested in an AS population in a phase 3 trial and did not show any efficacy. Similar outcomes for a study in apremilast in ankylosing spondylitis and for risankizumab, one of the IL-23 inhibitors. Now, these are all studies in AS populations. It may well be that our axial PSA patients are different to our AS patients, and it's possible that these drug treatments may show different efficacy in axial PSA versus AS. But at the moment, we don't have clear evidence of their efficacy in axial PSA, and therefore we've not recommended them for use. So this is the final draft Grappa recommendation flowchart. This is very similar to the recommendation flowchart we had in 2015, although you'll note it's been twisted. So rather than running from top to bottom, oh, and I made it disappear. From top to bottom, it runs from left to right. So you can see the recommendations for each of these different domains, generally following a step-up approach, but with some key exceptions where people need to escalate up to more effective therapies. So for peripheral arthritis, we would typically consider NSAIDs and DMARDs first, but if you have access, there is an expedited route with the arrow where you can use biologics first line if that's available to you. I think what's key here is that we think about the blue boxes either side. So we should be considering all of the different domains in an individual, what drugs their patient has had before, whether there's a patient preference, and any comorbidities or related conditions when we're choosing a therapy for a single individual. And then obviously we're going to treat the patient and trial a medication, but if that's not effective, this would be an iterative process where we then trial another medication and monitor response to get patients well controlled. So as a final update, we are now finalising the comorbidities table to add to the paper. This was presented for feedback at the Grappa annual meeting in 2021. We're aiming to submit this paper, as I said, a week tomorrow. So we're under a fair amount of pressure at the moment. And we also have 8 domain group papers which are summarising all of the literature, which will be published alongside the main recommendations. Thank you very much.
Thank you. Thank you very much, Laura, for that usual clear and comprehensive presentation. We're not having questions right now. We will a little bit later on. So you can go away if you'd like to come back a little bit. That would be lovely. Thank you. So we're running a little bit behind, but so we'll move on. Our next speaker is Dennis Pedubney, who's a professor of rheumatology at the Charité University Hospital in Berlin, Germany. Now, Dennis couldn't be here live, so he's recorded his presentation, but he should be here for the Q&A session. And Dennis has focused mainly on the early diagnosis, treatment, and outcomes in patients with axial SpA. He's a member of the executive committee of ASAS and has authored a number of publications on the topic of spondyloarthritis. So I'll now pass over to Dennis. Thank you.
Dear ladies and gentlemen, it's my pleasure to talk today about axial manifestation of psoriatic arthritis, definition, diagnosis, and management. Here are my disclosures. I would like to start with a clinical challenge. This is a case, a male patient, 65 years old, who came to us with intermittent inflammatory back pain lasting for 20 years. The response to NSAIDs was okay, slight improvement with diclofenac, taking not in a full dose. 4 months ago, he had a pain in right sternoclavicular joint with some swelling. So far, no clear diagnosis in this case has been made. Different physicians suggested degenerative disease, DISH, and there was also suspicion of ankylosing spondylitis or axial spondyloarthritis. The patient had a history of psoriasis for many years, and there was also a family history of psoriasis. At physical examination, there was no peripheral arthritis, dactylitis, or enthesitis, but axial mobility was substantially limited, especially in the lumbar spine. In a lab, HLA-B27 was negative, CRP, ESR were normal. So we performed the usual check-up as in a patient with suspicion of axial spondyloarthritis. So we performed X-ray of sacroiliac joints first, and as you can see here, there is no radiographic sacroiliitis visible here. So sacroiliac joints are virtually normal. The patient brought also to us a CT scan of sacroiliac joints, where you can see that there are no signs of inflammatory affection, no structural changes compatible with sacroiliitis, a little bit of sclerosis, some degenerative changes, but nothing really serious or suggestive of spondyloarthritis. Also, an MRI of sacroiliac joints, there were no typical structural changes, especially no erosions, no ankylosis, but already also no bone marrow edema, but already on those images, you can see that something is happening in the spine. And indeed, if you look at the spine, you can see that the spine is nearly ankylosed. You see a lot of new bone formation. Some of those bony breaches look like true syndesmophytes. Some of them look a little bit like spondylophytes. And with this picture, you can understand the difficulties from colleagues, because sacroiliac joints are completely normal, but there is a lot of new bone formation in the spine. You can see also here changes in vertebral bodies, and sclerosis in the vertebral body. You will see later on where the sclerosis came from. On CT, again, a lot of new bone formation and a mix of true syndesmophytes, or something that look like true syndesmophytes, and rather bulky bony breaches. In the cervical spine, nothing really serious, maybe degenerative changes here, but nothing comparable to the lumbar spine. And on MRI of the spine, you see that all those changes are very unlikely to be of degenerative origin, because you see a lot of inflammation on different areas, different vertebral bodies in a lumbar and thoracic spine. Here you see a really huge amount of inflammation involving also intervertebral discs, and here typical spondylitis, And on T1 weighted sequence, you see quite a number of structural post-inflammatory changes, those fatty lesions, and of course, a newborn formation were observed on previous X-rays and CT. So this would be highly suggestive of inflammatory affection of the axial skeleton, and we made the diagnosis of psoriatic arthritis with predominant axial involvement. So you can call it axial psoriatic arthritis, psoriatic spondylitis, or psoriatic spondyloarthritis. We're still working on unified nomenclature here. I would prefer to call it axial PSA. And here you see also not only the diagnostic challenge, but also classification challenge, because Caspar criteria are probably fulfilled because there is a clear inflammatory musculoskeletal involvement in a patient with psoriasis and family history of psoriasis, but because of the lack of sacroiliac joint involvement, the modified New York criteria and others classification criteria would not be fulfilled. And this is quite challenging also in the daily clinical practice, because when we think about axial spondyloarthritis, we focus a lot on sacroiliac joints, and in this case, sacroiliac joints were not affected. So let's come to definition and diagnosis. The issue is, indeed, there is no unified definition, no classification criteria for axial psoriatic arthritis. That is why I would offer you a very brief definition. How do I understand axial psoriatic arthritis? Axial involvement in PSA is characterized by inflammatory affection of the axial skeleton, sacroiliac joints, and or spine. We need to remember that in this patient population, isolated spinal involvement is really more frequent as compared to primary axial SPA. How frequent is axial involvement in psoriatic arthritis? We have some epidemiological data, but there is a substantial variability in the percentage given there because, again, lack of unified definition. Here, for example, data from the Caspar cohort that was developed for classification criteria for psoriatic arthritis. Here you see that spinal involvement was reported in about 14% of the patients. Here, a bit earlier data from Canada, from Toronto Hospital, Daphne Gladman and her group. And here you see that axial involvement those days was found in about 34% of patients. But do remember that at those times, only X-ray, maybe CT was available to diagnose axial disease. There was no MRI widely available to diagnose those patients at a stage before structural damage. Most recent data from the same group suggested that a unilateral radiographic sacroiliitis of at least grade 2 could be observed in about 45% of patients with psoriatic arthritis, and sacroiliitis fulfilling the modified New York criteria was observed in 35% of the cases. So this is probably the lowest margin of the potential range of the probability of axial disease in patients with psoriatic arthritis. If you look at the spine and if you look at MRI, this number can only be greater. There are some differences between axial SPA and axial PSA, resulting into challenges in diagnosis and classification. For example, the age of onset of psoriatic arthritis in general, but also of axial PSA is older than in the primary axial spondyloarthritis, meaning we're dealing here with older patient population with some degenerative changes in the spine and sacroiliac joints, which sometimes not very easy to differentiate from through inflammatory changes. Also, inflammatory back pain is less prevalent in this patient population, and we see, as already mentioned, more frequent involvement of the spine without involvement of sacroiliac joints. Also, B27, which is frequently utilized to diagnose axial spondyloarthritis, is less prevalent in this patient population. One of the frequently asked questions is, can we diagnose axial PSA based just on clinical parameters? And the answer here is no, but clinical symptoms, back pain, and especially inflammatory back pain, help to raise a suspicion of axial involvement that has to be confirmed by imaging techniques. Why inflammatory back pain is not very useful here? The reason is very simple. In the rheumatology practice, inflammatory back pain has a very low specificity. It is quite sensitive, but it has very low specificity level, and that is why inflammatory back pain is a good screening parameter, but not very good diagnostic parameter. What about imaging? Here we have several points to consider, and please keep those points in mind when diagnosing axial psoriatic arthritis. So first, radiography, X-ray, sacroiliac joints and spine is less sensitive and less specific than MRI or CT. Second, changes in the spine can occur in axial PSA, so without changes in sacroiliac joints. But remember that degenerative changes in the spine are very common and may look similar to inflammatory changes. I will show you a couple of examples in a second. And finally, active inflammatory changes, bone marrow edema, should always be considered in the context of structural changes. That means that the presence of typical structural changes increases the specificity of bone marrow edema that can occur also as a sign of mechanical stress in the spine or in sacroiliac joints. Which sequences are relevant to make the diagnosis of axial involvement in PSA? The same as in primary axial spondyloarthritis. Here we're talking about STIR or TERM or T2 weighted sequence with fat suppression for recognition of active inflammation, osteoitis, bone marrow edema. T1 weighted sequence is required to detect structural changes such as erosions, fat lesions, backfill, ankylosis, sclerosis, so the same spectrum of structural changes we see in primary axial spondyloarthritis. What I would also recommend you to do routinely in your daily clinical practice is to perform in addition so-called wipe sequence or gradient echo sequence. This sequence is very useful for detection of erosive changes because you see great contrast between cartilage and the bone. So look at this picture. Here we have a STIR image where we can recognize some bone marrow edema. And indeed, there is some bone marrow edema, but this is rather minor finding. And the question is if this bone marrow edema is really related to spondyloarthritis or to axial manifestation of PSA. To judge on this, we need to have a look at T1 weighted sequence. And here the picture is getting more clear because you have a lot of structural changes, fat lesions, erosions, backfill signs, so repair tissue in the erosion cavity. And on this background, interpretation of bone marrow edema would be very clear. It is really compatible with axial involvement of PSA here. Same is also for the spine. If you look just at the spine, you always have to consider what is the condition of the intervertebral disc. If intervertebral disc is healthy, you can think, yes, it may be related, this inflammation may be related to true inflammatory disease. But if intervertebral disc is degenerated, the interpretation is not that clear. Here, again, context of structural changes, fat lesions, also syndesmophytes, they all would help you to interpret this bone marrow edema in the right way. So what about the treatment? The question is, should we treat axial PSA as primary axial spondyloarthritis? The answer is the axial SPA approach is probably sufficient in the majority of cases, but the presence of axial involvement in PSA might guide the choice of a particular drug class for the treatment of psoriatic arthritis or psoriatic disease in general. If you look at EULAR recommendation for treatment of psoriatic arthritis, you can see that recommendations for axial disease is more or less a copy of current other EULAR recommendations for primary axial spondyloarthritis. So we start with NSAIDs, and if they do not work, we go to biological DMARDs, and here TNF or IL-17 blockers are recommended. Very similar picture can be observed also in the more recent Grappa treatment recommendations, which were presented for the first time this year at EULA and will be published very soon. Here you see axial domain. We start usually with NSAIDs. If they do not work, we go for biologics or JAK inhibitors, because JAK inhibitors also demonstrated efficacy in primary axial spondyloarthritis. If they do not work, we switch within these three classes. But formally, we still do not have data clinical trials conducted in axial psoriatic arthritis with NSAIDs, TNF, or JAK inhibitors, and the only piece of data that is available that can be considered as strong evidence is for IL-17 inhibitors, but we still use NSAIDs and TNF alpha blockers because we have some experience with those drug classes, and we do believe they work also in axial PSA. So let me show you a couple of slides on most recent pieces of evidence for two drugs which claimed efficacy in axial psoriatic arthritis. Here you see results from the Maximize study that was the first true attempt to address axial psoriatic arthritis in a clinical therapeutic trial. In this Maximize trial, the patients with psoriatic arthritis were included if they fulfilled Caspar criteria and if they had active spinal disease that was defined by the Barsday score of equal or larger than 4, and also relevant spinal pain. Already here you see that there was no requirement to confirm the presence of axial disease by any kind of imaging, because at the planning stage of this study, it was rather unclear what would be the most appropriate way to define axial psoriatic arthritis, and that is why MRI was included as one of the outcome parameters, but not as an inclusion parameter. Probably you saw this data. The study was positive, and patients treated with secukinumab achieved others 20 and others 40 response, and was substantially better than in patients treated with placebo. Also, if you look at the back pain score, because others 40, others 20 is a composite endpoints, having also peripheral domains here. In this case, we're talking only about back pain, and there was also a clear difference in the reduction of back pain between placebo and active treatment with secukinumab. Also on MRI, although not all patients had signs of inflammation on MRI, stressing again that population of patients with psoriatic arthritis and back pain is a very heterogeneous patient population, but in those patients with inflammation on MRI in the spine and sacroiliac joints, there was a clear reduction of inflammation associated with secukinumab, but not with placebo. There was another recent publication with guselkumab, IL-23 blocking drug, and that was not a dedicated study for patients with axial psoriatic arthritis, but a post hoc analysis of 2 trials with polyarticular psoriatic arthritis, where investigators recorded the presence of sacroiliitis on current or previous imaging. Here you see the results of this study, and here you see that both Barsday, spinal pain modified Barsday, so Barsday without question related to peripheral arthritis, demonstrated a better improvement as compared to placebo, better improvement with guselkumab as compared to placebo. So the only issue is with this study, this is a retrospective analysis of patient populations which presented with predominantly peripheral manifestations with polyarticular psoriatic arthritis. And so it would be more appropriate to have a dedicated study with IL-23 blocker to prove the efficacy of this drug also in axial domain, because you remember IL-23 blockade doesn't work well in primary axial spondyloarthritis. In the others, Grappa, we had a consensus on a need for a clear definition on in classification criteria for axial psoriatic arthritis. We started this initiative about 2 years ago, and currently we just started the axis cohort, axial involvement psoriatic arthritis cohort that will recruit patients with psoriatic arthritis, where we'll be looking for presence of axial disease. And I do hope that this study will result into development of clear classification criteria for axial psoriatic arthritis, and will help us also to understand the axial disease in patients with psoriasis and psoriatic arthritis. Many thanks for your attention.
Thank you very much, Professor Pedubney, for a very, very nice presentation. And we will be taking all of the questions as mentioned earlier at the end. So it gives me a great pleasure to introduce our next speaker, Prof. Laura Savage. She's a consultant dermatologist and honorary senior lecturer at the University of Leeds. Her research interests across the boundaries of dermatology and rheumatology, and relates to development of strategies to detect and manage early psoriatic arthritis in patients with psoriasis. Dr. Savage has recently been elected to the Grappa Steering Committee and has co-authored the published guidelines on the detection and treatment of enthesitis. So without further ado, Professor Savage, the floor is yours. Thank you.
Thank you very much. And it's my great pleasure to join you today to talk about how and why dermatologists can and should minimize the delay in diagnosing psoriatic arthritis in patients with psoriasis. So before I begin, here are my disclosures. So psoriasis should no longer be seen as a distinct disease entity, but rather as part of a spectrum of psoriatic disease, whereby up to a third of patients may also develop the musculoskeletal involvement, some of whom may also develop inflammatory bowel disease and the related autoimmune ophthalmological disease. So dermatologists may not achieve their treatment targets for patients if they do not consider the presence of psoriatic arthritis when managing psoriasis, as these data from the US National Psoriasis Foundation surveys and the Corona Registry show, whereby patients with psoriasis and psoriatic arthritis have significantly lower quality of life scores and worse cutaneous symptoms compared to those with psoriasis alone. So dermatologists are thought to be placed at an ideal juncture to try and identify psoriatic arthritis, given that around 80% of patients will have antecedent psoriasis. So through early recognition and intervention, be that either to start a skin-directed treatment with efficacy in psoriatic arthritis, or to facilitate timely referral to rheumatologists, dermatologists can play a proactive role in limiting the progression of disease, both in the early stages and then throughout treatment. In this prospective study from Toronto, where 313 patients with psoriasis and psoriasis were followed up for 4 years, the annual incidence of new psoriatic arthritis in the psoriasis clinic was 1.87 cases per 100 patients per year, rising to 2.53 when only those patients with at least one follow-up were analysed. So in my clinic, where we collectively see around 200 patients a month, this equates to around 60 patients per year, which emphasises the need for vigilance amongst dermatologists, so as not to miss the diagnosis and opportunity to intervene. However, even with perceived early recognition and diagnosis of psoriatic arthritis, several studies have shown not insignificant rates of irreversible structural damage at first presentation to a rheumatologist. So in these two studies, one from Dublin and one from Sweden, between 20 to 30% of such patients had radiographic evidence of irreversible joint damage, and that damage was then progressive over 2 years of follow-up, signifying the need for early intervention with the aim of reducing damage and, of course, limiting future disability. And it therefore appears that some structural damage may be occurring before the onset of clinical symptoms, which is usually the trigger for referral to dermatology. And this is likely due in part to the subclinical disease that starts at the enthesis. And several studies have looked at asymptomatic patients with psoriasis and found that a high proportion, up to 46%, have sonographic evidence of enthesitis despite being asymptomatic. So at the enthesis, there is very close functional integration between the tendon and ligament insertions and bone, where the insertions are splayed and anchored like the roots of a tree. And because of this close functional integration, the entheses are sites of high stress and mechanical trauma. And in genetically primed individuals, there is then failure of repair due to the absence of normal immune regulation. And this leads to chronic inflammation, which is thought to represent a deep Pacobna response akin to that seen in the skin in patients with psoriasis. Sustained inflammation at the enthesis then leads to tendon thickening and localized bony changes, including erosions and enthesophyte formation, and then with secondary dissipation of inflammation to adjacent structures within the synovial enthesial complex. So you may say, well, that's very interesting, Laura, but how is that of relevance to dermatologists? Well, as we know, psoriatic arthritis is a progressive disease, and there is a window of opportunity where we can intervene to improve outcomes in psoriatic arthritis. Indeed, it has been shown that if there is a diagnostic delay of a year or more, or a delay in a patient seeing a rheumatologist of 6 months or more, and to start treatment, then the patient is likely to have increased disability, increased signs of radiographic damage, and a lower possibility of drug-free remission. And so due to the development of subclinical musculoskeletal abnormalities in patients with psoriasis, it is therefore of paramount importance that dermatologists do not miss the opportunity to make an immediate onward referral to colleagues in rheumatology as soon as symptoms emerge and, of course, clinical suspicions arise, particularly if the patient reports emerging pain and joint tenderness. So a growing body of evidence supports the notion that the onset of psoriatic arthritis is preceded by a prodromal or a transition phase in which the disease starts to spread from the skin to the joints. And this state, which is characterized often by pain and joint tenderness, but not swelling, as well as the presence of distinct inflammatory joint lesions on imaging, is associated with a high risk to developing psoriatic arthritis. So this prodromal phase of the disease could allow the development of strategies for early disease inception, with the ultimate goal of trying to prevent the onset of psoriatic arthritis. However, before such strategies can be developed, it has to be clarified whether the symptoms of subclinical inflammatory joint lesions are sensitive to therapeutic intervention in principle. In my own work, we demonstrated a reduction in inflammatory features of enthesopathy on ultrasound after 24 weeks of skin-directed treatment with ustekinumab in a group of 23 patients. And in the more recent EVEPSA study of a similar sized cohort, 24 weeks of treatment with secukinumab saw significant improvements in the total PSA MRIS score and synovitis subscores on MRI, and no progression in erosions or enthesiophytes. So these early data imply that very early disease interception and in PSA, it may well be possible, and it provides rationale for the concept that early and tight control of psoriasis with biologic therapy may help to prevent the onset of psoriatic arthritis in high-risk individuals. So beyond the prodromal phase, patients with symptoms of inflammatory arthritis, then making a diagnosis of psoriatic arthritis, as we know, is not straightforward, and particularly not for dermatologists. The Caspar Criteria is the most widely cited classification criteria for patients with inflammatory arthritis, and it was validated as a means of classifying PSA for research studies and designed to standardize the inclusion of patients for clinical trials. So it's important for dermatologists to remember that the Caspar criteria is not a diagnostic criteria, and therefore the difficulty for us comes in determining whether the patient in front of us has inflammatory arthritis and then distinguishing it from mechanical joint disease or other arthritides. In the absence of a specific diagnostic test or commercially available biomarkers, then the diagnosis is made primarily on the history, the physical examination, and radiographic features, which dermatologists managing psoriasis should familiarize themselves with. So just to recap, the typical signs include obviously the presence of psoriasis or a family history of psoriasis, nail lesions, enthesitis, dactylitis, distal and or proximal interphalangeal involvement, and spinal inflammation. Radiographically, osteolysis and pencil and cup deformity, as well as ankylosis and new bone formation near the joint margins, are all indicative of psoriatic arthritis. So in terms of laboratory features, patients with psoriatic arthritis are usually rheumatoid factor negative, though remember that seropositivity may be present in over 10%. And then other features may include elevations of ESR and other acute phase reactants, such as a C-reactive protein. And elevated ESR, I think, is found usually in around 40% of psoriatic arthritis patients. So diagnostic difficulty is then compounded by the very heterogeneous nature of PSA, and patients may present with any combination of a number of different domains of disease. Dermatologists obviously tend to be most familiar with peripheral arthritis, but they may not be aware of the signs and symptoms of dactylitis, enthesitis, or axial disease. It's unusual for a patient to present with just one domain, as demonstrated in the Corona Psoriatic Arthritis and Spondyloarthropathy registry. In this, only 23.6% of a total of just over 2,500 patients with psoriatic arthritis had a single domain presentation. This chart here shows a subgroup analysis of 354 patients who were initiating biologic therapy at the time of enrollment into Corona. And these patients had a higher prevalence of all disease features, with the majority having involvement of between 2 and 4 domains, and only 12.7% had a single domain involved. So these results should therefore increase the awareness of both dermatologists and, of course, rheumatologists of the heterogeneity of disease presentations amongst patients with psoriatic arthritis, which is important for the development of an effective and comprehensive management plan. So there are some clinical clues that dermatologists can seek out to help assess if a patient has psoriatic arthritis. So as part of the history or assessment of skin disease, patients should be asked about joint stiffness. They should be asked about pain, tenderness, and swelling. The symptoms often have an insidious onset, and the stiffness is typically worse in the morning and lasts for 30 minutes or more. The pain and the stiffness tend to be eased by exercise and worsen after rest, and pain in the back or buttocks can wake patients in the second half of the night. And then there are associated conditions where we see a high prevalence of psoriatic arthritis, including IBD and uveitis. And of course, the presence of these should prompt closer observation, as should a family history of psoriatic arthritis. There are also some clues on examination of the skin. So if you see nail psoriasis, scalp psoriasis, or plaques around the gluteal cleft, then patients are reported to have a higher instance of psoriatic arthritis. And again, closer monitoring for PSA development should be provided for these patients. And then the nail in particular is a very strong cutaneous biomarker, with over 80% of patients with psoriatic arthritis exhibiting psoriatic nail changes, compared to 40% of those with psoriasis and no articular disease. So in patients with nail psoriasis, due to the close anatomical and biomechanical link between the nail root and the insertion of the extended tendon, enthesitis of the DRP joint is common and is nearly always found in early psoriatic arthritis. So a range of screening questionnaires have been developed to assist dermatologists to try and identify patients with psoriasis who've got psoriatic arthritis. And perhaps the 3 most widely used and studied are the PEST, the PAIS, and the TOPAZ. And of course, each have their pros and cons in terms of content and ease of use and the length. And of course, each perform very well in their development cohorts. However, when they were compared head-to-head in clinical trials, such as the CONTEST study as shown here, the sensitivity and particular specificity dropped considerably, which does question their usefulness in isolation. And I think it highlights the need for them to be supplemented with additional history and examination. The poor specificity, and it was highlighted in the EDUCATE study, where patients with psoriasis were asked to complete the PEST questionnaire in a primary care setting. And in that cohort, 15% of those with a score of 3 or more only had PSA. That was the suggested cutoff, obviously, for PSA and onward referral to rheumatology. The vast majority had other MSK disorders, with the majority having osteoarthritis. So a simple mnemonic to help dermatologists to identify what to look for in patients with psoriasis or PSA is MINDS, so that's morning stiffness, inflamed joints, enthesitis, dactylitis, and spondyloarthritis. And then perhaps another even more simplistic mnemonic that's taught by Joe Marola and colleagues to their residents is simply PSA, with the P standing for pain, S standing for swelling, sausage digits, obviously inferring dactylitis, and stiffness, and then finally A for axial arthritis. That could be quite useful to jog people's memories about the things to look and ask for. So when some of the things that dermatologists should not miss while you are doing your PASI assessment or your body surface area assessment include swelling or tenderness of one or more of the large joints, as we can see in these pictures here. Then to ask about fusiform swelling of a digit, the so-called sausage digit, which represents dactylitis. And then to look also for any tenderness or occasionally swelling at the site of an insertion of a tendon or a ligament into adjacent bone, particularly looking around the Achilles tendon or the plantar fascia, and then may be the most helpful place to look. And then, of course, to ensure that any examination is supplemented with questions for inflammatory back pain. It's typically pain that has been present for more than 3 months, insidious onset, typically begins before the age of 40, although not always, is eased by exercise, is associated with early morning stiffness, and can wake the patient from the second half of the night. So the difficulties with diagnoses that we've touched upon underpins to me the need for collaborative working, and dermatologists should not miss the opportunity to network and find like-minded and motivated rheumatologists with whom to combine forces and to try and work together to improve outcomes in psoriatic disease. So on a day-to-day level in the clinic, the dermatologist's initial relationship with colleagues in rheumatology for any patient will be to focus on their help in confirming the presence of psoriatic arthritis. But then long-term collaborative relationships are equally important to try and provide ongoing optimization of joint disease, obviously utilizing imaging where required. And then conversely, for the rheumatologist, the dermatologist needs to be readily available to confirm the presence of psoriasis and then to provide ongoing input into cutaneous disease control. And then together, both specialties have a role in monitoring therapeutic compliance and adverse events, and of course, screening for comorbidities. So if you're not fortunate enough to have a combined clinic where you've got both specialists sitting in the same room, then the best means of combining patient care is for dermatologists to be asking about peripheral and axial symptoms at every visit, to use a screening questionnaire annually, and to ask about function and overall quality of life, and of course to look for those signs of joint disease as we've discussed. Conversely, the rheumatologist, we would assess for the presence or deterioration of skin disease, and also ask about quality of life relating to psoriasis as part of their overall assessment of psoriatic disease. And then there are several ways that each specialty can raise their concerns about poor disease control, which of course will depend on your local circumstances. In some centres, such as mine in the UK, we have 2 clinics running parallel, so we can access one another immediately if we do need to discuss therapeutic choice. Other centres work collaboratively by scheduling a regular MDT meeting, either with or without patients present, to then discuss combined cases, or in other centres, sometimes concerns are flagged by email. And then, of course, those patients are then offered a priority clinic appointment in the other specialty so as not to delay treatment. In some centres, however, collaborative working is difficult to coordinate due to funding or geographical issues. So in these centres in particular, I think dermatologists really need to have an awareness of the treatment guidelines for all 6 domains of psoriatic disease, so that they can then consider what will be the most appropriate treatment to manage all facets. And as Laura has beautifully described from her presentation, there are nuances here in terms of the different domains, in terms of what's licensed and what's approved. And of course, in terms of what's licensed for psoriasis and psoriatic arthritis may also be different. It may be that a patient doesn't quite qualify for one indication, but does for another. An example would be a patient with psoriasis and axial involvement. There may be a requirement to use a conventional DMARD for the skin, but given how we've heard that these can be ineffective in axial spondyloarthritis, then the patient may be able to transition straight onto a biologic therapy. And so just to summarize, psoriasis and psoriatic arthritis are no longer seen as distinct disease entities, and as dermatologists, we may be ideally placed to identify early joint disease. Dermatologists should therefore not miss clinical clues in the patient's history and examination that may point to an earlier diagnosis of psoriatic arthritis, but it's not easy, especially in the absence of biomarkers. The presence of antecedent psoriasis, the majority of patients who are destined to develop psoriatic arthritis may give an opportunity to potentially circumvent arthritis development, particularly if biologic therapy is indicated in the dermatologic clinic, although of course further work is needed in this area. However, monotherapies for skin and joint are advocated in both dermatology and the rheumatology guidelines, and prescribers should not miss the opportunity at each treatment amendment to consider the differences in licensing, in dosing and routes of administration for the different domains of psoriatic disease. And then of course, dermatologists and rheumatologists should not miss the opportunity to collaborate where possible, as multi-specialty working is paramount to achieve best outcomes in psoriatic disease. So I want to thank you for your attention.
Well, thank you very much, Laura, for that beautiful presentation. We now have a short time for questions and answers. We are running slightly late, but you have all the speakers at your disposal here. And we already have one question in from Dr. Gamal Ibrahim, who I know very well. And the question is to Dennis Pedubney, asking about the limitations of the BASDAI as a primary outcome measure when when doing studies on axial PSA. Is it valid, or have we got to cast doubt on its use?
Yeah, very good question, and I think Laura Coates could also elaborate on this point. She wrote a beautiful editorial to the paper on guselkumab in axial PSA, and I think it is absolutely correct to say that BASDAI maybe not a good instrument to evaluate axial disease in psoriatic arthritis, just because it includes many parameters which are largely affected by peripheral disease. So question on peripheral arthritis, question on enthesitis, fatigue overall, this is all largely affected by the peripheral domain. So my preference would be, if we want to assess axial domain in clinical trial or in daily clinical practice, I would go for spinal pain and maybe also for morning stiffness. But spinal pain is a cardinal symptom of the disease, and this should be assessed as a main outcome parameter for axial disease.
Thank you, Dennis. Kurt, I've got a question for you. And it's a rather odd question coming from the home of the enthesitis hypothesis. But when you see a new patient in clinic, what you see is swollen joints, people with synovitis. And you did refer to Dennis McGonagall's original assertion that the synovitis was a secondary phenomenon. I think you commented that because it's an enthesitis organ, you get concomitant synovitis and enthesitis. But you know, when we see it in clinic, it's synovitis. People aren't presenting with predominantly enthesitis. So how can you reconcile that with all what you showed from theoretical and animal models?
I think there are two kinds of patients. You have patients with this kind of dull paraarticular joint pain, and if you take MRI of them, you see a lot of bone edema and enthesitis. And then you have other patients which have predominantly synovitis, but you see very often also in the adjacent structure some bone edema, which we consider as inflammation, but it's very difficult to prove, of course, except if you use IV contrast agents, which might be more suggestive for inflammation than for just, let's say, bone edema through loading. So it's true, but I think we see equally, let's say, para-articular joint pain, which can be illustrated by MRI and showing bone edema in the adjacent structures, and especially in early disease.
So we perhaps should be looking more carefully at these cases that Laura has described, who present with maybe arthralgia rather than synovitis, periarticular pain and tenderness. We should be perhaps doing more investigation, such as MR, on these cases.
Well, I think this would be interesting, because for a different kind of study, we including PSO controls, and the aim was to include PSO controls without arthritis. And afterwards, there was a number of patients who presented with arthralgias, and they developed overt arthritis in the next year. So I think, yeah, it would be a very interesting study to, in fact, to systematically examine a cohort of patients with definite skin disease and with arthralgias to see how many already have, let's say, inflammatory lesions on imaging techniques, and also to follow up over time to see if how many, a bit in the same style of the ultrasound study was done many years ago by Paul Gisondi. Yeah, I think that would be an interesting study.
Thank you. Walid, there are other questions?
No, I have a question for you.
For me?
Yes.
Go ahead.
Yeah, I mean, it's on the same line. I mean, I think ultrasound is being studied by Grappa currently as one of the tools, you know, for the outcome measures. And I think, you know, being involved in ultrasound for the past 18 years now, I wouldn't see a psoriatic arthritis patient without doing an ultrasound on that patient. And I think Grappa has a huge role in the future to empower, you know, rheumatologists especially to pick up, you know, the enthesitis and synovitis, and maybe further clarify the disease, not from the, you know, microbiome or the cytokine level, but at the joint and skin level. So that is, I mean, is a huge task towards Grappa, and I wanted your insight in that regard. Thank you.
Well, you probably know, as you've heard me talk many times, I'm not a big proponent of imaging. I rely on clinical judgment. But having had that conversation with Kurt de Vlaam, I perhaps should think further about imaging these cases of arthralgia with ultrasound or MRI. And I agree, Grappa has a role to play in this. And as you know, Grappa is trying to develop standardized ultrasound techniques and evaluation. There's a question for Laura Savage. How many percentage cases of skin lesions follow the onset of psoriatic arthritis?
Yeah, so I mean, from our perspective, it's, you know, I guess that's a question for the rheumatologist, because you will be the one seeing the emergent psoriatic plaques in your patients. But you know, and again, the question is how many of those are severe enough to then reach my door? Because often those who have the joint manifestations first, which is probably around 10-15%, they go on to then develop psoriasis. It's often relatively mild, and it remains under the remit of the rheumatologist. You know, I am often just called round to confirm that a single plaque is indeed psoriasis for my colleagues in rheumatology, because if it is a single plaque, it can make it more difficult to be absolutely certain. But often they're just given an appropriate topical treatment, and then they don't come to the dermatologist, and particularly because the treatments that you give them for their psoriatic arthritis are effective. So we think it's around 10-15%, but who knows what the true figure may be.
Yeah, it's difficult. That's sort of historical, isn't it? But as you say, nowadays, when we're both dermatologists and rheumatologists are treating with powerful drugs that can affect the other aspect or all aspects of the disease, that proportion may be obfuscated, or at least changed from what it was historically. There is a question for Laura Coates. Are you there, Laura?
I am indeed.
Hello. Yes, it's about this this wonderful flow diagram that is part of the old and the new recommendations. People love flow diagrams. I don't quite know why, but of course, as we've just seen from Laura Savage, people present with multiple domain involvement. So it's a question of how you, as it were, pass the information from those flow diagrams by domain into what you see before you in terms of patients. Are there any sort of simple rules you follow, or are you basically just presenting the evidence per domain and leaving it to the individual to decide what to do?
So yeah, I think you're right. I think it's really hard to create a flow diagram for something that doesn't really flow in one direction for everybody. That's something we deliberately avoided, you know, as opposed to sort of typical flow diagrams for treating rheumatoid arthritis, for example, where it's much more focused on one aspect in the arthritis. And so it's much easier to have a single straight flow diagram. The idea of the flow diagram is to summarize all of the evidence from those different domains, so that when you have a patient in front of you in clinic, you assess which domains are a problem, and then you can look at those individual domains and really see where there's overlap. So if somebody has skin disease and arthritis, I might pick methotrexate as a first-line option rather than sulfasalazine, for example. If somebody has axial disease and peripheral arthritis, I'm not going to want to use conventional DMARDs, although they may be beneficial for the peripheral joints. I'm going to end up jumping to a biologic therapy or potentially a JAK inhibitor in the future, because those drugs overlap between the peripheral arthritis and the axial disease. I think as we are more used to choosing therapies and things are getting more complicated, it's something that we have to really keep on top of. And I think for me in the clinic, it's often axial disease and skin disease that are my big deciding factors when I'm selecting a therapy. So a lot of the drugs are kind of equivalent for peripheral arthritis. You've got a bunch of conventional DMARDs with kind of similar outcomes. You've got a bunch of biologics with similar outcomes. But in skin disease, there's much more variation in terms of efficacy, good head-to-head data. And in axial disease, as I mentioned, we've got some drugs that work and some that we're just not sure if they do. And so I think those domains are the things that I find the most important to think about when I'm considering a drug choice.
Yeah, thank you. That's very clear. In the interest of time, I think we'd better move on. There's just a final question from Paramjit Singh about how common is hyperuricemia in psoriasis and psoriatic arthritis. It is more common in the general population. Up to a quarter of patients will have hyperuricemia. And some of those will, of course, have gout. And distinguishing gout and PSA sometimes can be difficult. But yes, you're right that we do see more hyperuricemia. So I'd like to thank all the speakers for their contribution. You are now released. We still carry on with as the local speakers, so Walid and I still have a little bit of work to do, but thank you to Kurt, Laura's, and Dennis for their contribution to this meeting. Thank you.
Thank you.
Thank you.
Bye-bye. Bye.
Thank you very much. Bye-bye.
So I'd like to introduce our next two speakers now. First of all, Dr. Ahmed Abogamal, who's a professor of rheumatology at Al-Azhar University. He's accredited EULAR musculoskeletal ultrasound teacher and has participated as an organizer, speaker, instructor, and trainer in many national and regional and international rheumatology conferences. He's an active member of Grappa. I know he has a particular interest in dactylitis and has published many research articles and abstracts. So Dr. Abogamal is going to go first, followed by Dr. Amin. So I'll leave the floor to you, Dr. Abogamal.
Okay, thanks to Philip for the nice introduction. So if I share my screen, can you see my slides?
We can.
Yes, okay. Okay, so I'll talk about psoriatic arthritis management. So with the value of dermatology support to our treatment or management of our patients. This is my disclosure. This talk actually sponsored by Novartis. Psoriatic arthritis is almost a common autoimmune arthritis affecting almost 30% of patients with psoriasis, with the extent of psoriasis is mainly a determining factor to developing psoriatic arthritis, with special interest areas like the scalp, intergluteal areas, and other areas like plantar psoriasis. It is always believed that the psoriatic arthritis starts mainly at the interstitial inflammation by activation of the inert T cells with induction of inflammatory cytokines, starting by interleukin 17, with subsequent increase the vascular blood flow in the subcortical area with invasion of inflammatory polymorphonuclear leukocytes, with further secretion of TNF alpha and interleukin 22, with the combined picture of erosions and bone formations. My patient already I first seen in June 2019. She was female, 35 years old, with psoriasis for almost 10 years. She has on and off mild skin lesions affecting her scalp, hands, and sole of the feet, and usually controlled by just topical steroids and some kinds of shampoo for her scalp. But lately she started to describe progressive bilateral hand and heel pain recurrent over the last 3 months, which was well controlled by NSAIDs in the form of ibuprofen. But the main driving factor that let her come to my clinic was severe left ankle pain and swelling with almost antalgic gait for over the last week, which is not controlled by non-steroids. Her clinical assessment showing symmetrical arthritis affecting the DIB region, mostly in the second, third, fourth, and fifth on both sides, with intensive swollen left ankle with severe tenderness and swelling, with also tenderness and swelling over the peroneal tendon areas, left Achilles tendonitis and bilateral plantar fasciitis, and showing just small scattered scalp psoriatic lesions and behind the ears. There was no, at that time, no dactylitis, no sacroiliitis, and no evident nail lesions. The complementary lab showing ESR a little bit high, 27, and positive CRB in the form of 11, and the evaluation scoring at that time for her psoriatic arthritis showing DAPSA score of 33, so they have very high active disease, with lead incitis index showing bilateral Achilles site showing score of 2. The ultrasound assessment of the Achilles tendon, as we are showing here, we have a significant distension of the bursa with a positive Doppler signal overlying the area of the interstitial attachments and the bursa, and also in the tendon. And actually, this is based on the last Omerect definition. This picture fulfilling the definition of ultrasound picture of enthesitis of the Achilles tendon, with showing activity, and also the activity based on the Doppler signal density is about 2 to 3 grades. There's extensive ankle fusion and arthritis, and we can see here is the second part of the plantar fascia in the longitudinal assessment of the inferior surface of the calcaneus. We can notice here is the distended part of the plantar fascia, which is already covered by hypoechoic part of the inflammation denoting enthesitis of the plantar fascia on both sides. On examination of the lateral part of the left ankle showing in short axis here, we can notice the post-peroneal tendon showing inflammation with hypoechogenicity surrounding the synovial covering, plus the Doppler signals that affect already present in the tendon and in the synovial covering as well, denoting tenosynovitis, both in short axis and in long axis. Based on the Grappa recommendations that we have now, 2 domains mainly affected the peripheral arthritis, so we should start with NSAIDs, and we have to go for conventional DMARDs plus corticosteroid injection if indicated. And for enthesitis, we have to rely on NSAIDs, corticosteroid injections, and physiotherapy as initial part for the management. The action done, the patient starts in conventional DMARDs in mesothelioma in the form of 20 milligram once per week, adding gobizone 5 milligram, and corticosteroid injection already infiltrated for the left ankle and peroneal tendon under ultrasound guidance. And in the further follow-up, the patient have a significant response, but still reporting the bilateral hand pains, and still we have a significant enthesitis in the form of plantar fasciitis, Achilles tendonitis, but the skin is almost clear with no skin lesions. The assessment score showing a reduction of the VAS almost 50% up to 4. ESR, it is improved to 18, and CRB is borderline positive at the level of 5. DAPSA score improved up to 18, but still in the active side. But the lead Incidence index is almost stays the same. It's a score of 2. So based on that, we have to move to a second step of based on the guidelines to enter the biological side. We have to select between TNF inhibitor, interleukin 17 inhibitors, or ustekinumab. And based on this, we step up the treatment by adding the Cosentyx 150 milligram with the loading dose protocol, plus continuation of the conventional DMARD methotrexate 20 milligram once per week, with adding a local injection steroids for the plantar fascia in both sides. 3 months later, we have a significant improvement in the VAS down to 2, with the ESR and CRB almost normalized, with DAPSA score down to 7, and we have normalized leads Incidence index with 0 almost enthesitis. Based on that, the DAPSA score is not yet reached the remission level or as a target of treatment. We increase the dose of Cosentyx up to the 300 monthly dose, with going down with methotrexate to 10 milligram once per week. And the result was very impressive. That patient already reached significant remission by DAPSA Blue 4 as a 3 degree, and patient reaching MDA with VAS 1, CRB 1, and the Incidence index is almost 0 as the same. The patient continue in a significant remission, and later on, after the almost 1 year of MDA, the patient continue on Cosentyx as a monotherapy at 300 milligram once per month injection. Almost 3 months or 6 months back, the patient already developed. In the follow-up, we have a significant falling of the nails, which is painless, falling of nails of the 4 fingers in the left hand without any significant lesions before, which already occurs suddenly over a period of 3 weeks in the follow-up of this patient. This is a picture of the left hand of the 4 fingers of the nail lesion before falling. So this actually development of the nail lesions left us about different questions. Is this actually could be defined as a treatment failure? Because this patient already in the previous visits have a significant remission based on the MDA and DAPSA score, and already normalized lesions in ultrasound and examination. So no active lesion as regards the psoriatic arthritis, and no previous history actually for the nail lesions. So the question is actually you have to switch the interleukin 17 blocker to a different mechanism of action, either going to TNF inhibitor, interleukin 23, or JAK inhibitors. But based on the history of this patient, actually without any history of nail lesions, we decide to ask help from our colleagues in the dermatology department at Suleiman Habib. So based on the dermatological advice suggests that there almost is another factor could be a fungal infection that could be the cause of this onset of nail lesion and nail fall. And he recommends to do the fungal nail culture or sample from the lost nails, which proves the presence of fungal nail infections. And the treatment decision was to add the antifungal treatment for the current medication, with continuation of the same treatment with a good response after a couple of months of treatment. Going back to the literature showing this, the Candida infection interleukin 17 inhibitors, as interleukin 17 is known as a protecting agent against infection, especially for the Candida species. And the psoriasis itself could be also an adding factor for increasing the risk for Candida infections. So patients with treatment with interleukin 17 inhibitors may be left at a little bit high risk for developing infections with Candida species especially. Going back to the systematic reviews that showing that patients treated with interleukin 17 antibodies show increased risk for Candida infection, up to 4% with patients treated with brodalumab, and 3.3% in patients with XZ, and 1.7% in patients with treatment of secukinumab. Actually, this case represents the value of consulting dermatologists, even patients have already severe psoriatic arthritis and almost the skin is clear with no evidence skin manifestations or other nail manifestations. So continuation of treatment is in continuous remission of the patients, and also adding their dermatology consultation helps to figure out the cause of nail lesion in such case. This was my case presentation, and thank you.
Thank you. Should we move on, I think, in the interest of time, to Dr. Ahmed Amin, who's a specialist of dermatology and venereology at the NMC Specialty Hospital in Abu Dhabi. Dr. Amin has participated in many clinical trials as principal investigator in both psoriasis, atopic dermatitis, and acne, with many publications, posters, and abstracts. He's an international fellow of the American Academy of Dermatology and European Academy of Dermatology and Venereology. So, Dr. Amin, over to you.
Thank you, Dr. Philip. It's my pleasure to be in tonight's meeting. I will talk about psoriatic arthritis from a dermatologist's eye. So that's my disclosure. First of all, I will go through a case series which has happened to me really in last year, consultation with one of my patients. So Mr. Johnny, the 50 years Greek gentleman, came to my clinic 1 year back, complaining from a skin rash in back and extremities. So we start the conversation by, good morning, doctor. Good morning, Mr. John. How are you doing? He told, not good enough. That's why I'm here. So I asked him, tell me, what's the problem? He said, I developed skin rash in my back for the last 2 months. Then it started to spread to my extremities as well. So I asked him if there is any associated symptoms, itching, body pain, burning. He said a little itching and some joint pain that I don't think it's related. So I told, while shaking your hand, I felt some swelling in your joint. Is this normal? He said, all started together. And I consulted an orthopedician and he told me some arthritis and it will go away, but nothing changed. I told that is see your skin. So after complete examination of the skin and full assessment, he asked, tell me, doctor, what's your opinion? And if there is any relation between skin rash and joint pain. So I told, I have a good news and bad news for you. The good news that you have a disease, we can control it. But the bad news that it may be a friend for a long time. So he told, what does this mean and how we can control it? So I told him that your diagnosis is psoriasis, and there is definitely a relation between your skin rash and joint pain. And you have to see a rheumatologist at the earliest, as a skin disease can be reversible easily, but joint affection, maybe not. So he asked me, what kind of treatment you're going to prescribe? I told him, if you're concerned, if the skin only, I can believe that it can be easily controlled with a topical treatment. But the main concern now is the joint, as you have a significant joint affection in multiple places, and the rheumatologist may suggest a biologic therapy to control the joint, and it will control the skin as well. So he started to ask, what's biologic therapy? And I gave a brief explanation about biologic therapy, how it would work, and all the related concerns. So he started to say, sorry, I cannot take any injections, I don't like it. And I have a strong belief that a changing lifestyle, sports, and healthy food can beat any disease. So I start to give him a little more time, long discussion. Unfortunately, there is no change in mind. So he started to say, I totally understand your idea, doctor. I will contact my doctor in home country and I'll keep you updated. So the conversation ended like most of conversations with some of our patients. And unfortunately, after 9 months, there is bad news. Mr. John came back again, walking hardly with a very tender joint in both hands, and he didn't tolerate even handshaking. And he started telling, sorry, doctor, you were completely right. I admitted in the hospital for 15 days for a frozen sacroiliac joint, and I was not able to move for 3 weeks. His rheumatologist recently started a biologic therapy. The skin cleared fast as usual, but unfortunately, his joint slowly improving. So from this story, we have an important message that I need to highlight tonight. We need to keep, as a dermatologist, our eye open for all the manifestations of psoriasis disease, as patient will never correlate skin rash with other extracutaneous manifestations. We need to make a proper explanation about disease and related comorbidities. The longest time of my consultation is with a psoriasis patient in the first visit. We need to explain everything related to the disease. We need as well to discuss the treatment options in detail. We need to follow up with the patient, and we need to highlight the alarming signs. Every single psoriasis patient, I'm telling him that 1 out of 3 patients can have a psoriatic arthritis. And I'm not telling this to be panic, just to keep in your mind, if you got a joint pain anytime, it may be related, just let me know. So we need at least to highlight these alarming signs to our patient. Then when it comes to the refer, we should refer the patient officially from a medical legal point of view. So I will share one of my cases which have a psoriasis disease, a package, generalized psoriasis, very extensive disease, obese patient, 46 years, male patient with a history of psoriasis 20 years ago. He have an obesity, dyslipidemia, reduced glucose intolerance, liver steatosis, and unfortunately have nail psoriasis and monoarthritis association. As you can see in the photo, there is significant erythema and swelling in the third distal interphalangeal joint. That was very painful. Nail psoriasis in the same fingernail, ultrasound synovitis with a positive Doppler signal and joint edema, X-ray showing minimal bone erosion. So this case is an example of the psoriasis disease, psoriasis with multiple phases, skin affection, nail affection, joint affection in a patient with a comorbidities. Definitely, as a dermatologist, I will not only look to the skin clearance. I need to clear the skin. I need to improve the nail situation. I need to improve the joint. I need also to use safe medication can control all these comorbidities with the patient. So from this case, we need now to redefine our treatment goals to start to prevent the damage associated with the psoriasis disease. And maybe we'll be able to reverse the existing damage. So we are not only looking to the skin anymore, we are looking beyond the skin. We need to prevent any inflammation to be affected to the other organs. We need to control this extracutaneous manifestation. And if we are able to reverse an existing damage, it will be a great job. So what happened to our case while we are treating the patient in a proper way with a collaboration with the rheumatologist? So after 12 weeks with a biologic therapy, there is a complete skin clearance. Treatment was well tolerated. There is no any worsening of the metabolic parameters. And we got a significant improvement in the nail and joint. Patient received an intra-articular steroid injection together with a biologic treatment with a significant reduction in the swelling and improvement in nail psoriasis after 12 weeks. So this is one of the successful stories that we'll cooperate together, we work together, and will help our patient positive. As we know that we have phases of this psoriasis disease, and there is a very casual link between the psoriasis and psoriatic arthritis, starting with the psoriasis itself, then a preclinical PSA, the subclinical PSA, then the significant PSA that can happen. And this can happen silently, starting with the silent inflammation phase, and then later on, the classifiable PSA can happen. In that time, definitely, maybe the treatment will not be helped anymore once we have a deformity of the joint. That's why starting the treatment as soon as possible is a very important point in psoriasis treatment. Unfortunately, psoriasis as a diagnosis can be delayed up to 2 years, but the more problem is the PSA, which can be late diagnosed up to 5 years, and this is definitely will lead to a permanent destruction, or maybe at least there's an irreversible destruction in the joints. We are the first point of contact to our patients, as 75% of the psoriasis patient will start in the skin only, 10% of them can only start with the arthritis, and 15% can start together. So this awareness is a very important point to be completely understood from the dermatologist, because they are the first point of contact in most of our PSA patients. As per all the guidelines from all the associations that they are guiding us to make an annual assessment for a psoriatic arthritis for any psoriasis patient, especially in the first 10 years, as this is the time that we need to pick the psoriatic arthritis, and we need to treat this patient as fast as we can. How we can do this? We have to increase the awareness. We need to educate the patient that there is multiple phases and there is subclinical inflammation can happen anytime to psoriasis patient, and you just need to be aware if any of these symptoms happen, you have to come back to us. Very simple questions. We can ask our patient about morning stiffness, joint pain, swelling in specific joints, peripheral joints, and tendon Achilles. Simple examination. You can just touch these joints, search for a swelling, search for tenderness, especially in the peripheral joint. Every visit, every 3 to 4 months, we just need to ask these questions if there is any joint pain, any morning stiffness or not. And we need to ask the help of rheumatologist once we need. Now, with the new Grappa update, we have multiple phases of the disease. We need to be completely aware. We are not only looking to the skin, we are looking to all the phases of the psoriasis disease to start to pick the best treatment for our patient. We need to know which domains are involved, because now we have one stone can kill multiple birds. So we need to write it down, all these manifestations, and we see which is the predominant domain which is be affected, and we need to use the medicine which is approved in multiple indications to control the treatment. So we need to know which domain is the involved, which domain is the predominant, to pick which treatment we can pick for our patients. Unfortunately, if we become late, the structural damage can be irreversible. In the first year, 25% of the patient have only more than one erosion. Later on, 2 years, we have double. 10 years, we have 60% of our patients, they have more than 5 deformity joints. Late diagnosis by 6 months is enough to increase the odds ratio, the probability of the erosive disease, arthritis, mutilans, the disability, the deformity of the joint. Once if only we are late in the diagnosis, more than 6 months, we have the probability of all these structural damage of the joints can happen. And definitely most of these things are irreversible. With year by year, all this will happen. Unfortunately, we can reach to the level of increased mortality due to cardiovascular comorbidities, which is casually linked to the psoriasis and psoriatic arthritis as well. Now, what's the difference between good, better, and best in psoriasis in PSA treatment? I made a casual indirect comparison between adalimumab, secukinumab, ixekizumab, guselkumab. Based on the latest data has been published in the head-to-head studies. We have a head-to-head adalimumab versus secukinumab in the EXCEED study. We have ixekizumab versus adalimumab in the SPIRIT study. And we have the Discover 1 and 2, the guselkumab. This is a randomized clinical trial phase 3 data, not a head-to-head. But as we can see here, we still have a superiority of IL-17 blocker, secukinumab, and ixekizumab in achieving CR20, CR50, and CR70. In all these parameters, we have a superiority for the IL-17 blocker over the TNF adalimumab and guselkumab as per the last published data for all these medications in psoriatic arthritis treatment. So when we need to work together, when I have to knock the door of the dermatologist and ask him for help, we need, if as a dermatologist, if I has a doubt that this patient may have a PSA, we will have 2 schools. The first school that he will refer from the first visit for a rheumatologist, especially if the joint affection is significant and you have a mild skin disease. So in that time, maybe I will refer back to rheumatologist, or sometimes I will start to pick one of the biologic therapies which have multiple approvals. As we know that IL-17 blocker have an approval in psoriasis, psoriatic arthritis, and ankylosing spondylitis as well. So I'll be pretty sure that it will work for the patient. So sometimes I will start straight away and I give a chance of 3 months. If the patient not improved, definitely I have to knock the dermatologist's door, ask for help. Maybe it's something else associated with psoriasis. If the patient improved, I will continue the treatment. I will end with a very important sentence that until a cure is available, all of these diseases are non-cure. Only control we can do, the best treatment is what we offer, a best ratio between improvement in the skin, the clearance versus the safety versus the side effect and inconveniences. So very important point, to choose the treatment, have a balance between efficacy and safety. And thank you very much for your attention.
Thank you very much, Dr. Amin and Dr. Abou Gamal, for 2 excellent presentations, which illustrate very well the need for us interdisciplinary specialists to work together in this important disease. And I think Laura Savage emphasized that, and I think you've made the point very well in both your presentations. And indeed, tomorrow we're going to have a workshop on collaborative working with myself and Dr. Miriam Wittmann. So we'll revisit this topic then, but thank you again, both of you. And so, Dr. Waleed, shall I give the quiz results now?
Yes,
or would
please.
you like to have any comments to make on that?
Yeah, but I mean, just maybe a note for yourself. Professor Ahmed Abou Jamal is working with me and Jamal right now in the same hospital. So that's
A good team.
Yes, we are becoming bigger and bigger.
Good.
Go ahead for the quiz results, please.
Just may I add one comment to Waleed before going to quiz results? I just need to highlight in this session with the combination of dermatology and rheumatology to refer back to the data of Dublin registry, which is published by Haroon almost, I think, more than 10 years back or something like that. He stated that patients already with psoriasis who visit the rheumatologist in the first 6 months of the disease, even that they don't have any significant symptoms, already have a better outcome over 50% as regards the bone erosions and the quality of life over the patient who has not visited the rheumatologist after the 6 months of the disease. So that's what we always recommend that patient, once you have a psoriasis, it's better to go for rheumatologist even for assessment, because psoriasis is very famous with subclinical joint lesions, either enthesitis, sacroiliitis, and even axial disease in some situation, which actually needs a very careful imaging workup plus the clinical experience to figure out the specific domains. This is my comment.
Yeah, thank you. Thank you very much. Shall we go to the quiz results then?
Yes, please.
So the first question was, what is the most important cytokine in the development of psoriatic arthritis? The actual answer was interleukin 17, which 71% of you already identified before Kurt de Vlam's talk. So congratulations to those who've voted for interleukin 17. Next question. And treating the skin will prevent the development of joint disease. This is an important question and one that's come up several times this evening. And there is some initial evidence that that may be the case, but it's not yet proven. So might be is the correct answer. Again, you're all very well informed, and congratulations to those who voted for that answer. Next question. So drug therapies, which drug therapies are recommended for axial PSA in the new Grappa recommendations? And of those combinations, TNF inhibitors and IL-17A inhibitors were the correct answers. So again, well done. The majority of you got that right. Clearly, JAK inhibitors may have a role to play there in future, but that's not yet proven. And the next question was, what drug therapy is recommended to treat PSA in patients who have active inflammatory bowel disease and uveitis? And the correct answer to that was TNF inhibitors, except etanercept. Again, well done, everybody. The majority of you got that right. Obviously, 17 inhibitors have not yet got any evidence base for uveitis and would not help in the bowel disease. The next question was, what is required to diagnose the presence of axial involvement in a patient with psoriatic arthritis? And the correct answer to that question was active inflammatory or structural changes on imaging. Again, well done. The majority got that right. Inflammatory back pain, as we've seen, is an unreliable feature and therefore can't be used entirely to diagnose the presence of axial involvement. Next question. And the next question was, which drug class is currently not recommended for the treatment of patients with psoriatic arthritis and predominantly axial manifestations? And the correct answer was, of course, apremilast, the PDE4 inhibitor. Yes, you're all doing very well here, and I don't think we can teach you very much. And I think there's one last question, is there? Or maybe two. Patients with psoriasis at the following sites have a greater likelihood of developing psoriatic arthritis. Well, there was an interesting combination here, but in fact, the correct answer here is scalp nails and natal cleft, not scalp palms and soles and nails. So I think this is one where you didn't quite get right, but I mean, the scalp and the nails are certainly correct. But the natal cleft, intertriginous psoriasis is also a high risk factor for the development of PSA. Next question, I think, is the last. And the question was, on average, patients with psoriasis destined to develop PSA do so. Now that was one of the options, but there were several questions here. There were several statements, and you were asked to identify the correct statement. And in fact, you have identified the correct statement, which was, the PES questionnaire includes questions to help dermatologists screen psoriasis patients for peripheral and axial PSA. In fact, none of the questions in the PEST are specifically directed at axial involvement. But I would, as a developer of the PEST, I have to defend it in the sense that only 5% of our patients with PSA have pure axial involvement. So the other 95% will be identified with the PEST questionnaire. And of those, about 30% will have axial involvement as well. So it's not quite true to say that we don't pick up axial PSA, because we do in the majority of cases with the PEST questionnaire. Thank you for those. And it only remains for me, almost on time, I'm glad to say thank you for attending, and thank you for all the speakers, the local and international. And I'll leave Dr. Waleed the last word, and we hope to see you all again tomorrow.
Yeah, we were hoping that to have you over in Dubai this time, but hopefully next year.
Hopefully, yeah.
Tomorrow we have a very rich program. I do encourage people who are able to come and visit, they have attend physically, because it's going to be one of the the times that we can meet old friends. I don't think that everybody likes this virtual meeting, so I would encourage everybody to come tomorrow morning at 9 for the morning session. I will be physically there at 2, before 2. And then we will have a great meeting, hopefully, to get both dermatologists and rheumatologists together. Have a good night, everybody. Enjoy your night and stay safe and healthy. Thanks, everybody.
Thank you.
Bye-bye.
Bye.